Hi, everybody. Last but not least, definitely with the longest unnecessary title. But this is about a patient who had an aortic dissection. It went into their celiac artery. So we put in a stent and that saved them from having fulminant liver failure. So let's jump in. So as most of you guys know, so we have type A aortic dissections, which are a surgical emergency. We have the Stanford classification. So type A involves the ascending aorta, type B involves the descending aorta, and the DeBakey classification, type 1, 2, and 3. Type 1 is going to be both ascending and descending, and you can see the other ones there. As you know, an aortic dissection involves a tear in the intima of the aorta, so blood will extravasate into the aortic wall, as you guys already know. And so why is type A a surgical emergency while type B is not? Because type A can dissect back into the coronary arteries, causing an MI. It can go up through the carotids, causing a stroke. It can also come back and cause aortic regurg. You can also get tamponade and have obstructive shock. So that's your quick overview and review. But not only is aortic dissection complicated, you can have complications from the surgery and the bypass as well, which I'll talk about a little bit later. And so other complications, you can have an aneurysm of the expanding dissection, it can rupture, it can occlude arteries, and that can cause malperfusion and end organ damage, as you guys know already. So there's been case reports in the literature about ischemic cholecystitis, pancreatitis, hepatic dysfunction, hint, hint, and mesenteric ischemia. Where's my clicker? So here's our patient. She's 39. She only has a history of hypertension. That's it. No other medical problems, no other relevant past medical history. She came in, classic symptoms, severe acute chest pain radiating to the back. Now, a lot of times folks with aortic dissection might have focal neurological deficits, or they might have unequal pulses. We learned that in medical school, right? And so this patient didn't have either of those things. She just had that pain and the hypertensive urgency. Her systolic was over 200. So they did a CT. You guys can see the dissection. Let's see if this laser pointer works. Perfect. So you can see on the inside here, pardon my 8 cups of coffee shaky hand. The inside here is the true lumen. The outside part is the false lumen. And then here again, you can see the true lumen here. And then this part is the false lumen. This is where it's dissected. You can see the head vessels coming off up here. The dissection stops before it gets to the head vessels. So no involvement of the head vessels. And you can see here that the dissection does not involve the aortic valve, which is around here. So this is a type A, DeBakey type 1. Here we can see that the dissection involves the celiac trunk. So this is just for my own learning, in case anyone else also has this issue. I always ask, how do I know which one's the true limit and which one's false limit? So here's 2 ways I found in the paper about this. Number 1, the false limit will have the acute angle called a birdbeak sign. So if you look, the false limit has these little corners on it. Sometimes the dissection looks flat through the middle, so you can't really tell. But just in case you can't see those little corners, that one's a false lumen. A lot of times the false lumen is bigger than the true lumen, though not always. Another thing you can look for is calcification, right? Those are going to be in the true lumen because the aorta is the one that's suffering atherosclerotic damage throughout the first blood. But in this case, you can't see the calcification. Why? Because that's where the contrast is. Contrast and calcifications are really fun. Okay. So here we can see the celiac trunk, the false lumen extends into the celiac trunk. You can see it's kind of cool plot here. And then we see it here again. All right. Okay, so for this patient, first thing we did, heart replacement, as we do. We basically replaced this part of the aorta. Remember, the head vessel is not tall, and the aortic valve is not tall either. So we did something that looks like this picture here. This definitely heart replacement. So we didn't have to do anything fancy with that. All right, so here's the front X-ray. You can see the sternal wires, the spongiatic catheter, and then I think this over here is the replaced part. So far, nothing out of the ordinary. Here's where the problem started. Postoperative day 1, patient starts having problems. Number 1, AKI, tracking local 4. Number 2, leukocytosis. Now, both of those can be complications of the bypass itself, which I'm going to talk about later in the presentation. But the focus of our presentation here is that she's got lactic acidosis, she's got high IRL 2.9, lactate was 11, and she had ALT of 1700. So we were worried about what? Hepatic ischemia. We were also worried about bowel ischemia. This image, I don't know if you remember the previous image, but this liver looks a lot more evidence than it does in the previous image. And so on the imaging, it looks like the dissection is also going into the estimate, right? So we're worried about bowel ischemia. And so in this case, what's our next step going to be? Emergent head clot. So again, just a recap of where we are so far. Patient had a type A dissection, they had a celiac artery dissection. Now we're worried about imminent hepatic failure, high INR, high AFT, lactic acidosis. We're also worried about
problem is that the liver was failed to cheat, and there was no valvular signal in the common hepatic artery. So we found that the celiac trunk was totally 99% stenosis. So here's what they did. They flooded a big cell catheter through the aortic arch, starting with the brachial artery. I'll show you the images in a second. But they threaded the wire through the celiac trunk, through the common hepatic, into the GDA, and then they inflated the balloon right here, and then put it in the perimetal. So let's look at some of the images. So here's the aorta. Here is the celiac trunk. You can see that there's like basically nothing coming out of it. They kind of forced the wire through, and you can see that there's a little bit of flow getting to the liver once they can force the wire all the way through. So here again is the before. The balloon's not inflated yet. This is the sketchy blood flow that's not really working coming through to the liver. After they inflate the balloon here, you can see it's kind of hard to see, but the blood flow does look better coming through here. And then once again, one more time, this is the celiac trunk before. This is the celiac trunk looks a lot better after the balloon. And then here's the SMA coming down. Here's the SMA coming down. All right. So this is very confusingly placed red line. It should be here after POD2. So what happened? So our patient came in pre-op. INR goes up to 2.9. This is basically where she had the stent placement, and then over time goes back down. Platelets I'll come back to. The AST peaked at 5,000 on POD4. It recovered by POD20. ALT also recovered by POD20. Why is platelets here? Platelet thrombocytopenia is another complication of bypass surgery. Bypass surgery, cardiac surgery. We'll talk about this. Okay, so here's our discussion. So this patient obviously had hepatic ischemia as a consequence of aortic dissection extended into the diaphragm. Now, malperfusion of end organs is not uncommon in setting of aortic dissection. Happens in 30% of type A's and 20% of type B's. There was no other reported case in the literature though of any stent in the celiac artery to correct fulminant and prevent hepatic. So let's talk a little bit about other reasons why we have liver failure in the setting of aortic dissection, right? So why are you going to have end organ disease? Either the organ's not getting enough blood, or the blood doesn't have enough oxygen. So why would the organ have to get enough blood? Well, during heart surgery, we have to stop the heart from pumping and kind of get the blood out of the heart in order for the surgeon to be able to work on the heart. So many of you are probably familiar, but essentially, a cannula is inserted here in the SMC right atrium and the IVC. Usually there's another set of holes here. I can't say it. So the blood comes out through the venous line, goes into our oxygenator through the bypass pump, and then comes back in, and they dump it back here into the aorta. A cross clamp is put across the aorta, and so that kind of isolates the heart away from the circuit so that blood can be taken outside of the body and put back in. Now you might say, well, how does the heart muscle not infarct during this procedure? Basically, they run some of the blood that's been oxygenated through and add potassium to it, and then dump it into the coronary arteries. So this does two things. One, that can stop the heart, and two, the oxygenated blood allows the heart muscle to continue to get oxygen even while the surgery is going on. So all of that rambling is just to say that there's a lot going on during cardiac surgery. The blood is being taken out of the heart, put back in, the heart's not working, we have to stop the heart during the surgery. And so after the surgery comes off, if you have a long cross-clamp time, so a long time that connection on the aorta, when you take it off, we have something called low cardiac output syndrome, which basically means the heart doesn't want to wake up. It's trying to wake up, or trying to get it to come, but it's waking up slowly. Low output means low perfusion to our end organs, means end organ damage, right? The next thing we can have is people who have an aortic dissection that have this type of surgery, you can imagine, be on a ventilator for a long time. If they have respiratory failure, low oxygen in the blood means low oxygen getting to the organ, means organ failure, right? There was one case report I saw of a guy that had cardiac tamponade that led to right heart failure, blood back to the liver, and that caused liver failure in the setting of dissection. So there are some other reasons why, other than in our case where the dissection went into the diaphragm, causing liver failure, these are some other reasons why you might have liver failure. I already talked a bit about the bypass, but one of the things I want to mention is that when you go on bypass, all of these patients, when they come off bypass, have a systemic inflammatory response. Why is that? You're forcing all the blood to go outside the body into a foreign system, right? This system is breaking up with platelets, so you're going to have thrombocytopenia. It's going to cause a massive inflammatory response, release cytokines from all of the contact with these foreign surfaces. And so this patient had liver psychosis, which is not unexpected. Another thing is remember that the kidneys get 20% of the output of cardiac output. And so anything that's causing our cardiac output to go down can also affect And in our case, we put in a stent that helps open up that artery to restore flow to the liver, right? But what else could we have done? Well, we could have done it in anastomosis. That sounds difficult and scary, and I don't know what to about it. Plus, we didn't have time. I think that's the main reason why I didn't do anastomosis. This patient was going into acute fulminant liver failure. They did bypass and liver option, just literally putting in like an artificial artery to go around the dissection one. Again, that's going to take time, and it wasn't a good option for our patient. So, for our patient in the long term, she would have to be on antiplatelet, anticoagulation therapy, and antihypertensive therapy for that complication. There's also 2 case reports that we found of a celiac occlusion in the setting of aortic dissection. Both of them were type E. Remember, ours was type A. In one of the cases, they did open up that celiac trunk using expandable stents, but that patient didn't have an end liver failure. The other case was kind of interesting. They did have a celiac trunk dissection, but the patient also had this artery. So basically, even though they had a dissection, it was the artery kind of pulled the blood up from the SMA to feed the foregut this way. So they didn't actually have a stent. In summary, our patient had an aortic dissection. She had an artery replacement. She had celiac artery occlusion and hepatic hypoperfusion, and then urgent reperfusion with the stent. Now, I will mention that one complication that unfortunately did suffer an ischemic stroke. It was found after the operation was done. So she was discharged with skilled neurological facility. But I'm happy to report that she is recovering. She's able to speak now. She's walking. She's ambulating. And so she's doing a lot better now. As 4 or 5 months post-op. And so, essentially, the main message here is that celiac artery stenting after aortic artery replacement is a viable option for patients with type A aortic dissection and celiac artery stenting. Thank you.
All right, so any questions?
At which point in her course did she suffer her stroke?
They realized that she was having a stroke when she was unable to come off of the ventilator. But basically, she had a stroke between the first arch replacement and all of this stuff happening with the X-lap. But because the ischemia was a more urgent issue, they wanted to take care of that first. But neurology was consulted between POD1 and POD2. And then the workup found that she had a stroke after that. Yeah. That is a great question. Can you repeat, what was the first part of the question?
Because the scan showed that it looks at least like the dissection involves the celiacs
Yeah.
and the initial scan. Like, not for this patient, but would there possibly be like at the index operation, do the initial graft where you like reconstructed the type A part,
Yeah.
but then also the descending aorta, like would you do it concomitantly?
Yeah, I see. That is a great question. So I think what you're asking is, why didn't they do the replacement and also like do
Yeah.
stent and descending
Yeah.
aorta? You know, that's a good question. Why didn't they do that? I think the answer why they didn't do that initially was because she did not have signs of endocrine damage in the beginning. Like I think her lactate, I remember from her last lactate for iron. So I think they could have done that, but in the beginning they were not worried about it. So that's a great idea.
All right, if there are no further questions, that is our final presentation for the morning. Thank you so much.
Thank you.